So thank you for joining us for today's Spotlight webinar. So my name's Sarah Ames and I'm an improvement advisor at Somerset Foundation Trust, and I'm also a really big fan of the Evidence for QI project. Evidence for Quality Improvement, or E4QI, began life as a Q Exchange award-winning project, and it's now been awarded further funding from the Q community supporting Q Connections programme. The mission for E4QI is to equip quality improvers across healthcare with the knowledge, evidence and best practice that they need to make better decisions and deliver better outcomes more efficiently. Today, we're delighted to welcome you to the next of our Spotlight sessions, and these are an important part of the programme of events that are planned over the coming year. So, for example, they also run 1 hour QI bite-sized training sessions, focusing on specific tools. Each Spotlight session will feature a different team or organisation across the health and social care, and they'll be showcasing and sharing the story of how their organisation is delivering quality improvement. So we hope you find this session a fantastic opportunity to learn from and be inspired by your peers. And in this session, we're delighted to welcome the Quality Improvement team from Kent Community Health NHS Foundation Trust to our virtual stage. The session will be led by Sarah Donovan, who is Head of Service Improvement for the team, and she also has her colleagues Robin, Jo and Amy with her to assist. Thank you, that's good. I've given you a little wave there. So over the course of the next hour, Sarah is going to share with you the journey and direction of travel for the QI team at Kent Community NHS Foundation Trust, and especially how they're spreading QI and getting more people involved. And we'll have time for questions at the end of the presentation. So feel free to raise your hands with any questions at the end, or type it into the chat box. So I'm now delighted to hand over to Sarah.
Thanks so much, Sarah. That's great. I would say nice to see everybody, but because of the screens and the way they are, I can't see a lot of you. So I'm just going to start to share my screen. So hopefully the background will be replacing. You can all see our KCHFT holding slide to begin with. Can I just check that everybody can see that? Yeah, is that all right for everybody? Fantastic. Great. So Sarah, thank you very much for the fab introduction. We are from Kent Community Health Foundation, Community Foundation Trust. I'm sorry, that's me. Someone's got a bit of a background noise on. I don't know if it's my speakers or someone else's speakers. It's a bit disconcerting. Thank you. That's gone now. That's fantastic. So good afternoon, everybody. My name, as Sarah introduced, is Sarah Donovan. I am Head of Service Improvement for Kent Community Health Foundation Trust. I have a varied background. I'm an administrator by background. I've worked in a number of different industries, but I first came into improvement working in heavy manufacturing and doing some lean work, because obviously if you don't get it right first time, you can't sell it, you don't make money, and really kind of got caught up with the improvement ethos. I then joined the NHS 13 years ago this month. Actually 14 years ago this month, which is great. I've just had my anniversary and I've been in this post for the last 5 years. I'm also a accredited QSA associate, so I have done the QSA practitioner course from NHS England and have done the assessment with the college to be able to be part of our internal faculty and to deliver the QSA practitioner training going forwards, which is important because that's the where the start of our journey kind of happened. As Sarah has said, I do have Jo and Robin, who are my 2 QI advisors on the call. I'm going to be delivering the bulk of the slideshow. I won't take up all of the time, I promise, because I might be telling you things that you don't necessarily have a lot of interest in. So I will open it up to questions and answers at the end and hopefully have more time for that than actually sharing the slides with you. And also I have our QI support coordinator, Amy, on the call as well, in case anyone has any kind of more structural questions about the logistics of how we do things and things like that. So they will help me answer the questions at the end, but I'm going to do the bulk of the presenting. I think they've all given you a wave already, but if they haven't, they can do so. They're the only ones that I can see on my screen, so I don't know if they're the only ones that you can see. So that's the plan really for the next sort of 20 minutes. I'm just going to, as Sarah said, take you through kind of where we have been as a community health trust, why we decided to do QI in the first place, and then where we are at the moment and where we're going. So up on the screen at the moment is kind of our pre-COVID journey. You won't be able to see all the details. We can send the slides out afterwards if people are interested, but a lot of what we have is also on our website. We have a standalone public facing website, so a lot of the things that I talk about today are going to be on there. Please do come and have a look. I recognise some of your names from Twitter, so I know that our comms officer is really active in the QI Twitter movement, so hopefully you will have seen or made some of the links, some of you already, but that is there for everybody as well. Michelle, thank you. Yes, Jane is fab and it is a great website. They worked really hard on it. Your resources are also great and I always look forward to reading your tweets. So this kind of shows where we are. So we started in April 2028. Obviously, improvement has been around for quite some time. I'm going to say the Productive series. I first came into improvement in the NHS through the Productive Community Services, the Productive Ward, all those things that were based on lean. Obviously, that kind of when the Strategic Health Authorities disappeared, we're going back a really long way now, that kind of started to fall apart. There wasn't the same driver. But improvement has been around and is obviously gaining so much momentum within the NHS because we do need to do things. It's not the same as it used to be. There isn't the money. We need to be attractive as an organisation and as an institution. So in April 2018, we decided that we needed to do something. So our execs at the time went to East London Foundation Trust. I do need to credit East London Foundation Trust because we got a lot of our starting principles and they gave us a lot of support at the beginning of our journey. And then decided whether or not we wanted to go down kind of the strategic partnership route with IHI or somebody like that, or whether we wanted to kind of try to do it ourselves. So we engaged with our senior leaders at the time. And what we decided to do was we would follow the QSA, the Quality Service Improvement and Redesign kind of journey that NHS England pulled together. A lot of us went on the course. We created ourselves a faculty and we spent a lot of time in the beginning setting up our training system. So we put a lot of effort into our QSA practitioner cohort. We developed a variation on our one-day course because we felt that the way to really get going at the beginning was to make sure that there was enough people within the organisation, those early adopters who were enthusiastic, to really start to push kind of the knowledge and understanding, because quality improvement to a lot of people, especially those that have been in the NHS for a really long time, doesn't really mean anything. It's very subjective. There's lots of different things that you can think about. So we did really focus on starting our training program and being able to deliver that in-house and also to our system partners as well. So we have had participants on our training program from Kent and Medway Partnership Trust, which is our system mental health trust, and also our acute trust as well. I think we've got a couple of people on here from KMPT. I think I saw their names. So yeah, that still is valid. We do try and work a lot across the system in terms of partnership all the way through. So we did kind of focus on that. We started to get our website together. We looked at all of our resources. We recruited to the team that you see today, Joe, Robin and Amy, and also from our comms perspective, we also have a partial whole-time equivalent for analysis purposes, so data. That's been really helpful. And we were going absolute great guns. We'd had Hugh McCoffey, who was the Director of Improvement, come down to see our hub. We don't have a hub as such at Kent Community Health because obviously we're a community trust, but we kind of have a QI wall in our headquarters that everybody can see when they walk through the door, just to try and get that message going through as osmosis. Hugh had been down literally the day before COVID hit and we went into lockdown. And then what we found was, unfortunately, with the pandemic, the QI programme got mothballed. That's not to say that we didn't use our expertise in the projects that we were doing and that we were supporting. So, for instance, I supported a cross-system end-of-life project during COVID with medical support over out of hours and things like that. So we were still using the skills, but the programme itself had to kind of come to a halt. We then also developed a virtual training offer once it became apparent that we wouldn't be going back to the face-to-face immediately. And given that we put a lot of our focus on training in the beginning, that was quite difficult for us to think about. And we've kind of spent the last 18 months resetting the services, helping our services reset. So we have all the community services ranging from health visiting, school nursing, community nursing, specialist services. We do have some community hospitals as well. We're very much a therapy and nursing led workforce. We do have some medical staff, but not that many. So it may look, our version of QI may look very different to, say, an acute version of QI. We also have lots of geographical challenges. We're not on 1 or 2 sites. We have at least 93. So spreading our message can be a little bit difficult. So we've also really focused, as a result of COVID, but also because of our geographical challenges, on some of our digital resources as well, just to make sure that we can go as far as possible without actually having to meet face to face with people. So what I'm going to do just now is share with you a video to move into that's where we was and this is where we're going. This is the video that we currently show at our corporate induction for all new staff coming in and at the beginning of all of our training sessions. And kind of hopefully what it does is encapsulate what it is that we're trying to achieve, and what quality improvement means to us as a trust within KCHFT. I think that I've done it right, so it will share the sound with you, but if anybody doesn't get the sound, it's just music. There's no narration or anything like that. It is just the music, so if you don't have it, that's absolutely fine. Also, it's a bit loud, so if you do have a hearing sensitivity, you might want to turn your volume down a little bit. Hopefully this is going to work. So that's just a really kind of quick introduction to what QI means at KCHFT. And I think the bit at the end where it says QI for everybody is really the realization that we've come to in our kind of journey around QI. In true QI fashion, we are constantly looking at what we do and how we offer and make it something that people just do as part of their jobs, rather than QI being another thing that we have to do on top of everything else. What we want as a trust is for QI to become the way that we do everything. So hence the title at the beginning, QI is everybody. We want everybody to be involved, and that's kind of post-pandemic where we're really starting to look. So at the minute on the screen is our new trust strategy. So there's been a lot of work done in the last year on our new trust strategy, and because we wanted QI to become the way that things are done, it's been considered as a key enabler for this entire strategy. So everything that we have done or have got planned for our QI programme over the next 3 years is linked into this strategy that has that trust. So where we talk about a lot about making sure that people link projects and pieces of work into strategic aims of organisation to increase buy-in and things like that, we try to take those rules and principles of QI and actually apply them to our QI programme. And so that's where we are. So we have an organisational strategy for 5 years. It was literally just published this last April, and especially in terms of the great place to work and the sustainable care. The QI programme is a real enabler of those. Obviously, it touches on the putting communities first and the better patient experience. But what the organisation has been fantastic in doing is also making the measures for the strategy also smart and achievable and all those sorts of things. So again, we've taken the principles of QI. Our exec lead is our Chief Medical Officer, and she has been heavily involved in obviously creating this strategy with our board and our executive. And you can really see that there are some elements of QI that are running through this. So we're kind of trying to get it embedded in our culture, going upwards as well as going downwards. So to that end, what myself and the team are really working on underpinning this and as an enabler to our recare strategy, we have a driver diagram. So we don't have a big ream of text or anything like that. What we've done is we created our phase 3. So our phase 1 was setting up our training program. Our phase 2 was kind of coming out of the pandemic. And now that we've realised that we want to make QI business as usual, we really want it to be the way that people do things. If they have an issue or a challenge, they immediately come to, well, what is it that I'm trying to do? How will I know that I've made that improvement? And what can we do? What ideas do we have? That model for improvement that we base everything on, as well as then using the tools and techniques so that people can see them in action, and we are role modelling as a team what we're trying to get people to do, what we're trying to support all of our clinical teams and our non-clinical teams to actually put into place themselves to help them to make the changes that they really want to make to enable them to deliver the best patient care. So this is our phase 3 driver diagram. It's taken us up to the end of 2025. We've got 3 primary drivers. We want to achieve an aim of outstanding in our well-led CQC inspection by making that cultural change. So we've got something around increased spread and adoption, building capability and confidence in continuous improvement techniques, of which QI is a massive one of those. Really working on the model for improvement and focusing on data and measurements. One of the things that pandemic allowed us to do was really see where our gaps were. Our training program was well established, but we were finding that people weren't necessarily taking that away and translating that into work because the day job got in the way, because it was still seen as QI is something we have to do on top of what we're already doing, rather than a way and a means of sorting through what we want to do in a way and an enabler to achieve that. We think that that's been really important. So we've got the model of improvement, and then the last one is the biggest change from our previous driver diagram, which was around communications, because we've now got the website and a lot of resources available, is about ensuring that culture of QI within KCHFT is fully integrated. Now, I know that also a kind of a thread of conversation that we've had through the QSA Associates group and often on Twitter is, how do we prove the value of our programme? And we are no different. We have struggled with that. We've looked at various means of evaluation. We've looked at the Kirkpatrick method, all those sorts of things. But what we've decided to do now is just pare it right down and to be really simple. So we have a raft of 6 key measures that complement our primary drivers. Some of them are using data that is already available. So you can see here, we've got something around the staff survey question, because obviously there's significant amount of baseline data for that from the staff surveys annually, and also now the quarterly pulse surveys. And we are being reasonably ambitious, but we don't think it's unachievable. We have broken the golden rule of not necessarily setting yourselves a target of 100% because something could go wrong. But in terms of our QI training or our QI participation, we felt that we absolutely would need to have 100% so that people didn't feel excluded. And this is all of our colleagues, our staffing cohort, and also all our training is also open to our service users as well. So that is inclusive. So we've really tightly bound our outcomes of the programme and proof of our effectiveness to these 6 measures. And that's what we're working on. And that is how we are going to be able to say at the end of 2025, this is the difference that we have made and this is the impact. And hopefully by then we will be a long way through embedding QI into the culture of KCHFT, so it becomes the way that we do things. As part of those metrics, Amy pulls together every month a dashboard that we look at. We have a steering group, quality strategy implementation group that's been in place since the start of the QI journey. That is chaired by our Chief Medical Officer, and it also has quality representatives from all of our operational divisions. And we all come together and we talk through what we're doing. They were instrumental in pulling together the driver diagram and agreeing it. And one of those metrics is the spread and adoption, and the training is really fundamental to that. So whilst we recognise that maybe when we started our journey, we concentrated too much on training to the exclusivity of everything else, actually what we realise now is that training, it underpins everything, but it's the post-training support that's also really important. We have a staffing cohort of just over 5,000 individuals, and we have currently trained, if nothing else, from corporate induction to webinars to participation in collaborative workshops. So somewhere where a QI tool has been discussed, used, or the methodology has been discussed and used, 45% of our organisation so far, which, considering we are a community trust, is a really, really big reach. So that's great. So we have at the minute 9 QSA College associates so that we can deliver our QSA practitioner training. That is our higher level tier of training. We're currently reviewing that to try and make it a little bit more real life, but essentially that is for people who are nominated by the service, who actually have quality within their remit, so that then they can be peer leaders within their service or their team. We run a number of collaborative sessions. So over the winter, we tested a new model where instead of necessarily just doing a whole load of training, we actually went and worked with nominated services on a wicked problem around demand and capacity and spent substantial amounts of time with them. So working a much more collaboratively. So we count people that have been to the workshops that have done that because we've worked through tools and techniques. Obviously, QSA Practitioner, QI Fundamentals is our 1-day course. And as a result of the pandemic, we have now also developed our 2-hour QI Lite, which is delivered purely virtually. So that is open access as well as the 1-day course, but not everybody can be released for a day. The QI Lite is a 2 hours fully virtually delivered course that is open to absolutely everything, and that has been really, really successful. And then we do bespoke sessions, myself, Robin and Joe. The training is mainly done by the team. I think now I saw a quick question. The training is mainly done by myself, Joe and Robin, but also the quality representatives. So there are assistant directors of quality in the operational services. A couple of those are accredited with the QSA College. My assistant director is also accredited, and also our Chief Medical Officer got herself her accreditation, and she has delivered some of our QI training as well, which I think is really, really important because it has given it that kind of seal of approval, that stamp of authority right from the beginning. This is backed up right from the top. So this isn't going somewhere. It is new and it is different, and we do want you all to do it. Everybody can get involved because it's about making our own lives and our own working lives and the care that we deliver to our patients so much better. And you can't parachute somebody in to do that. It has to be done by the people doing the work. But having that real senior buy-in from the start was massively important to us. So we're really proud of our QI training programme. We do also have on our website a series of bite-sized videos. Some of you may have already seen it. So again, people tend to forget what they learn in the training, and then they come to it 3 weeks later and they think, oh, I know I really want to do a driver diagram, but I can't remember how to do it. So with our tools, our core toolkit that we cover in our 1 day and the virtual course, we have a series of bite-sized videos, a bit like YouTube. That was a really steep learning curve, putting those together, the process that we went through. But again, they're on our website. They're open to absolutely everybody to have a look at, and they are there as a continual refresher for anybody that's undertaken our training who wants to then do a piece of QI work, or is in the middle of a piece of QI work, or is just getting involved but hasn't done any training at all. That resource is there for them to have a look at all times. So that's kind of where we are, keeping an eye on our training numbers, because that is the part of the kind of the fundamental, you know, to build capability and to build confidence, you have to increase your knowledge base. So that's kind of where we are with that. And this is kind of the sort of really visual metric display that we're using. So our dashboard has those 6 metrics that I talked about previously, and that is used in all of our reporting through our quality committee and our quality reports as well. So it kind of all links in together. We're not doing a lot of different things in a lot of different places, and it all links to that broader strategy for the organisation. This is just a little kind of an organogram to show you that actually at the heart of everything are our QI advisors. I'm going to embarrass them now, but basically most of the work that is done through our QI program is facilitated by the QI advisors. They are placed in my team, but they work very closely with the assistant directors of quality within their operational divisions, and they have contact with QI project leads. They work on the subgroups because we have got a very wide range of services within our divisions. We have 4 operational divisions: pharmacy, adult clinical services, dental and planned care, specialist. Actually, we've got 5 because they've just split: specialist services, and then also a public health and prevention. And Joe and Robin, between them, are assigned to those divisions and help facilitate a lot of the QI work that are being done. They were not in place at the QI advisor post was not in place when we started the journey, but what we realised was as we were doing the training, that didn't automatically translate into work being done out in the services, and that's why we put the QI advisor posts in place, is to help support that after training action. And if people can't make the training, there's no reason they shouldn't get involved in a piece of QI work, because actually that's where most of the learning is done. So it's about really translating that real life kind of experience to build upon the knowledge that you've gained elsewhere. And around here, we didn't want to make this too fussy, but there's myself, there's the quality strategy implementation group, so the steering group, there are the assistant directors of quality, there are various other people around that help to support that. But the structure is mainly centred around the QI advisors and the work that they do with their divisions, assisted by Amy and steered by the steering group. So that's just to show you where we are. It also helps if we have people assigned to the divisions, they have that oversight, which we didn't have previously. We were very heavily reliant on people just telling us from a central point of view what they were doing. But now, because they've built those relationships with the individuals in the services, people do then come to them and go, I'm doing this piece of work, I just needed you to know about it, or I'm doing this piece of work and can you support me with it? And then that translates into a governance structure within all of our divisions. So that's great. So they don't have their own projects, they facilitate and support the projects of others. So a little bit kind of along the kind of QI coach improvement advisor route, but we call them QI advisors, but it's a very similar role. And obviously the shared learning and celebrating success is a massive impact, because we, particularly being a community trust, we do often find that there's a lot of solo working. And so having those QI advisors and the overall divisional boards and the quality steering group, we make it a lot easier to join all the dots up, which is really important, because then that means everybody has access to everything. As I said, we tried a different model over the winter, working with a collaborative. So it was a really it was about a year-long programme, and we worked on the wicked issues. We mapped it out, a little bit of a process map here, which is great, what was going to happen at each point. And this was really key for us in our learning going forwards about how to invite everybody and improve make improvement for everybody, because actually training isn't for everyone. It's about making sure that they have access, often looking at real world problems, and that is actually impacting on our review of our QC practitioner and all of our materials and training that we do. We're making them much more based on real life problems and issues, and working much more closely at base with teams through a training program. But what was really, really key here was the power of workshop and storytelling. Now I've chosen these images because you can see the variety of what we're doing. We've got a storyboard up in the corner, there's a Pareto tool on there, that's fantastic. But also just to reinforce our senior leadership, the person that you can see in the bigger picture is our new chief executive. She actually took some time out to come to one of our workshops in the collaborative and really played a part. And I would say possibly one of the biggest reasons that we have been so successful is because not only are we working really hard to engage those frontline clinical staff and the non-clinical workforce as well, because often they can feel a little bit disenfranchised or divorced from kind of going on about patient care all the time. They can't see the exact link, but also that senior buy-in at the top. So making sure that the message that QI is for everybody, and it should be the way that we are doing things, is reinforced from top to bottom. So that's kind of why I've done this. But you can see some of the different ways in which we were trying to utilize the tools so that people learned through doing. So where are we now? Building capacity, capability and confidence. That's really what we're looking for, putting that driver diagram into place. We've been refining the QI since our pandemic. We are looking at making our training more collaborative. We are working more collaboratively with project leads. We are bringing teams together more successfully between services. We are starting to run pieces of work, more strategic pieces of work with teams to respond to the things that are doing. All this while supporting the local level project work that's ongoing as well. And we do want to see that culture shift. We really do want QI to become the way that people do things. So they're not just sitting there going, we've got an issue, but we don't know what to do. We really want them to know how we're going to do it, and the 3 questions with the model for improvement, and then whatever else they want to use from our QI tools. But also then kind of thinking, okay, we've got something that's really good here. How can we scale it up and spread it and share that success with others as well? And that's the other key thing about our QI program, is actually really making sure that those voices and those success stories are heard. If you do go onto our website, we've got a projects tab on there. I think we have over 75 actual examples of projects. It's like our project library. We've got all those project summaries on the system, so you can go and have a look at those. And we really do want QI to become the key enabler for our strategy going forwards. So to do that, we need to make sure that we are also delivering as a team. So we do make sure that our support is monitored, and we get feedback from all of our training sessions and all of the project support that we do. And you can see that we're actually doing really well at the moment, which is fantastic. This was not always the case, particularly pre-pandemic. QI, as I said, was seen as something else we have to do, but we are certainly seeing that conversation shift, which is brilliant in terms of empowering our colleagues to be able to make the changes that they want to do. So kind of that's the end of me. We do have a website, as I said. I think, Sarah, we can send you these slides for you to share, or we can put some links into the chat and things like that. But if you put KCHFT QI into Google, it comes up at the top. I'm on it often enough to make sure that the algorithm works to do that. So kind of that's where we are. We've got some case studies on there. We've got all of our projects on a page on there. Our bite-sized, you can see at the bottom, a digital version of our quality improvement toolkit that we give out at our one-day sessions. We're also heavily linked in with the NHS England making data count movement. So we have based a lot of our measures training on their plot the dots, and they're making improvement, making every data count, or I can't remember the exact name of it, Sam's going to hate me, but that programme going forwards as well. So we're linking in with a lot of the national bits and pieces too. And of course, then we are very active on Twitter as well. So that's where we are. Any questions?
Thank you very much, Sarah. The chat was very active whilst you were talking. It was sparking all sorts of questions. And I think Robin Amy and Joe have been really good at answering quite a lot of those as we've gone, but there are still some other ones and some that came in right towards the end. What I'll do is I'll run through them, the ones I don't think have been picked up, but if there's anything that occurs for anyone, please feel free to raise your hand, or and then we'll come to you that way and make sure that we've picked everything up. So right at the outset, there was a couple of questions around the video, because that was really popular. People were interested to know who made it and what software was used.
It was done by our communications team. We have a really good communications team, and they've helped us with our website. And this was the second kind of intro video that they've done for us. So we did a lot of learning. The first one was done outside externally. They took a lot of learning from that. In terms of the software, I wouldn't know, but I could probably ask the question and get back to you. But it was all done in-house with our comms team.
Thank you. Yeah. I don't suppose that's anything that's available on the website, is it? When people go and have a look at your resources?
The video is on there. It's at the bottom of the front page. But again, I don't think that would help in terms of what software it is or anything like that. It's just literally the video.
No, but it's great for people to have a chance to view it again. So it kind of did everything in a very short space of time, didn't it? So there's some other questions about the driver diagram. And I found the metrics really interesting. So a couple of people were quite interested to know if they'd be able to see the driver diagram again, which I guess that's in the presentation pack.
Yep. What, put it on screen now or just to share it?
I think probably being able to share it after, so people can have time to look through the detail would be great.
Yeah, I think Amy could probably find the document, the PDF one, Amy, and put it into the chat for people so that they can have a look at it. Thank you.
Perfect. And then we had some questions about who delivers the training, and I think that was mainly picked up in the chat in terms of, is it mainly the QI advisors and people who are part of the QSA, who've completed the QSA college?
Yeah, so the QSA practitioner obviously should only really be done and delivered by QSA associates. So we've got 3 new ones who actually haven't done anything yet because we haven't run a programme, but we've got a core of 6 of us. We started off with 8 and then a few have left the organisation. So there are 6 of us that do the 5-day course, but then the 2-hour virtual and the 1-day fundamental is mainly myself, Joe, and Robin.
Excellent. And I see that there's a question further down in the chat as well about, you mentioned that you'd had great buy-in from your senior leaders and from your chief exec. And somebody's asked, Sarah Murphy's asked, how do you get the senior leaders on board?
It takes a really, really long time. I think we started with 1. So our chief medical officer, who basically, this was her brainchild. She decided we needed to do something from a quality improvement perspective, and she really drove it right at the beginning and continues to do so. The other execs, I would say, it's about proving the worth and getting them on board. It's when she can start to demonstrate the impact. And then we did have a change of chief executive within the last year, 18 months, I guess. And the new chief executive kind of re-energized it as well, because she is very much on the same kind of thought path around QI, has experienced it before, which has been really, really good. So that kind of fresh injection of enthusiasm right at the top has also been really, really beneficial. And then influencing the strategy to that effect as well. So the organisational strategy, and with QI being recognised as an underpinner of that, has also been really beneficial for the things that we want to achieve in the next 2 years and going further forwards as well.
Shall I go to Sophia? She's put her hand up.
Hi, Sophia.
Hi, really fantastic. I think it's great I made it here. I was in Tudor so that I'll get the time to come here, but I think I'm pleased I came here. So really thank you for your presentation. And it really resonates well. We are on a very similar maturity journey like yourselves, started in 2019, and what you guys are the curiosity in my mind that strikes in, and it's also a challenge at our end, and probably you guys might have, and I want to hear if this is a challenge for you guys, is how do you maintain the volume of support that the core team is asked of? Because like yourselves, we are also just a small team in numbers as you guys. And I saw your model is around providing that divisional support, and you're doing a more of a kind of a coaching support, and making sure that the principles of QI is maintained, is if I'm right in understanding that. How do you manage the volume? And I also saw your message around sort of you all don't get involved into QI projects, which might be high priority for the organization. My team does that too, also in addition to all the training capability. So my question is, how did you all push that back out to your senior leaders as to not getting involved into trust-wide sort of QI projects or very high priority or profile projects that need a QI head leading it or a QI manager leading it?
I think I'll come to Robin and Joe in a second, but certainly from my perspective, a lot of the kind of the strategic discussions and the capacity discussions are taken both with our steering group, and also my immediate line management is the Assistant Director of Business Development and Service Improvement, and she reports directly into our Chief Medical Officer. So that line of sight is completely there with us, with our SRO, and we are able to have capacity discussions at that point. I would also say that whilst we are getting there, we are currently not necessarily at a tipping point in terms of demand from the operational services, but we have certainly, particularly in the last 6 months, really seeing an increase in interest from those services and divisions. So I'm going to hand over to Joe and to Robin to kind of answer the second half of that question from their perspective.
Yeah, so I think I take on board what you say, and as Sarah said, you know, we've worked really hard to embed the QI culture, but with that there comes that need for services to tap into our support. So we are seeing a big increase. A lot of the strategic priorities, you know, with the We Care breakthrough strategy, a lot of the services are doing projects that are quite similar. So they might have different problems, but the essence of, you know, the tools they use and the skills that they've got is quite similar. So what I'm trying to do now is kind of marry up services together. So if, you know, health visiting's working on a DNA and reducing projects and it involves children, they can work alongside, you know, paediatrics, community paediatrics and some of their findings. So we're not starting from scratch and reinventing the wheel, you know, it's that peer support as well. Just so that we can, you know, really sort of spread ourselves, if you like, and really help people, because it is challenging managing like the innovation. So the staff ideas that come through us, we don't want to stifle that, because actually, you know, everyone's got great ideas, but it's also managing the strategic sort of balancing. So I do get that. I think we're sort of looking at how we can work smarter as well. So yeah, definitely peer support. You know, using some of our services like our patient involvement teams, they've got great ideas and they really follow a QI methodology approach. It's just kind of marrying up all of that so it's not particularly us all the time, you know. Hope that answers it. I don't know whether Robin's got anything to add.
I think the only thing that I'd add is certainly for some of our potentially smaller kind of team-based projects, actually, that have a really good outcome, and it's making sure that that is spread, because we know that sort of in the past teams have done very similar things along the way and they just do it and they just kind of, they may have had really great outcomes but they've done nothing with it. So I think that the oversight that Joe and I have and the input into our divisional boards, it's like you hear something, go, oh well actually so and so over in Tunbridge Wells, they're doing something really similar, or if we have some struggles within teams and actually there's a bit of sort of lack of enthusiasm around something, actually the great work that they've done, we've been able to go, okay, right, well we've got a team that wanted to do something similar down in Folkestone, let's give what you've done to them and let them trial it out, because you've kind of exhausted the team a little bit. They've done as much as they can, they're just a bit tired with it, and which we understand. Obviously they've all got busy day jobs and sometimes you can get to a certain point and actually they just run out of steam a little bit, and rather than losing all that good work, actually with the contacts that we've had and sort of over the past year or so, we've been able to go, okay, right, let's just pick that up where it is and let's put it into a new team, give them a go at sort of trialing it, doing some PDSAs, see where it lands, and then sort of making sure that we're spreading. Because I think sometimes also with projects, they want to see it to like full completion before they let it out into the wider world. So we're really trying to encourage them to say, okay, well, your PDSAs are heading in the right direction. You've done a lot of these changes. We know we're going to take data for the next however many months, but actually let's pass this to another team. Let's spread it out to the other community hospitals. Give them a go. Let's see how they feel about it, so that we're really making sure that those early improvements that we're seeing are really sort of spread and utilised by other teams as well.
Thank you, Robin. Sophia, do you want to come in with another question? And I noticed a couple in the chat as well that I'll pick up on in a moment.
If I can just ask one more, and then I'll keep quiet. I don't want to hog the microphone space when there are questions there. Just another curious question. And again, if you're able to share your structure and format of your divisional QI board, I'd be really keen to learn from you in terms of what your structure is, what's the responsibility, and how you run the show on your divisional QI board. Maybe after the session, if you can connect with me, that would be really great. I'd really like to, because we are setting up similar things, and if I can learn from what you guys have done, then I won't make the same mistakes.
I think, Sophia, in that case, that's great, fantastic. What we might do is send you the terms of reference for the boards that have been agreed centrally, but then every division has a slight variation, but the underpinning principles are the same. And then they all come up into the Q6. So there's not a lot in terms of, it's quite a flat structure, but actually probably the best document for yourself would be is if we just share our terms of reference. Tell you everything you need to know.
Thank you, Sarah. That'd be really helpful. Does anyone have any other questions that haven't been covered yet? Do feel free. We've got a couple of moments left before we close, so we've got time for another couple of questions if there are any. I think you've done a great job of answering as many as possible in the chat as well, so we've been very efficient today.
If nobody has a question, can I ask one more question?
Of course you can.
Since I've made it, I might as well, sort of throw that in. At your end, you mentioned around the teams sort of showcasing or bringing up innovation ideas. Does your innovation ideas also go into your divisional QI boards, or do you all have a separate strand for funding the innovations?
There's a separate strand for funding the innovation. So the head of innovation and effectiveness, who heads up the clinical audit team as well, she is one of our faculty associates for the QSA, so she's part of our delivery team, but also part of our quality steering group as well, so our quality strategy implementation group, because actually technically she owns our quality strategy, and she runs a separate innovation streaming. Well, what we do find is sometimes people aren't entirely sure what is improvement and what is innovation. So we are trying to work quite hard on the distinction between the two, but sometimes there is overlap. So if she gets something that's more of a quality improvement idea, she'll bring it to us. If we get something that's more of an innovation idea, we'll flag it to her. And the same with research as well. We do the same. If somebody needs to do something that's a more academic research-based piece of work, we liaise with the research team and vice versa.
Brilliant, because at the moment, innovation sits with my team. So we do innovation improvement together, and we fund 1 or 25k from our service sort of strands into innovation. So it's good to hear that there's a slightly different model. And I guess because of the way the reporting structure is structured within your organization would be my sort of guess. Brilliant. Thank you so much, team. I think I really enjoyed it.
Thank you.
Jo, did you want to add something, Jo?
Yeah, so as part of that, Dawn, one of our innovation leads, came this morning, and actually as part of our QI board, they showcased some of the software and emerging technology to gain interest. And one of the things that she was really keen around is, that we sort of work together, because actually we can try some of these in a very QI approach. So it was quite nice how it always fits together. So, with your QI boards, that can form part of it.
I think we also have a question around awareness days or celebration events. Sarah, thank you for your question. We do. The last 2 years we've had a conference, an annual conference that has been both face-to-face, in person, and delivered virtually over our YouTube channel as well. So we're not having one of those this year because we're concentrating on reviewing the model of training and things like that. But what we do find is that often when we have a conference, it's the people that can make it that will come, and they're often the same, and they're not necessarily the people that we that are the hardest to reach. And so we are looking at different ways of kind of moving ourselves around geographically. As I said, all of our projects, our finished projects, are published to our website. They are also discussed at the divisional boards, and certain projects are selected, and the project leads given the opportunity. They don't have to do it, they may not be comfortable to do it, but they have the opportunity to come and share their piece of work with their divisional management through their divisional boards. So yes, hopefully that's answered that question, Sarah. And also, if I could just go back to something that was a little bit further up in the chat, just to clarify, our QI data analyst, we don't have a single whole-time equivalent for that. We have a part of the broader business development and service improvement analyst role. So it is not a full-time role as Jo and Amy and Robin are. It is a part-time resource, but it is massively valuable for measures and data, which is a big gap for our organisation that we are trying really hard to plug, and that has been really helpful in helping us with that greater depth and understanding. We've always been really well linked in with our business intelligence team, but having that analyst function and having access to that resource is also really important for us. Thank you.
Great. I think that probably concludes all the questions, and we're very grateful to you, Sarah, and your team for the fantastic presentation and sharing all that detail with us, and your resources, which are really great. So thank you everyone who's attended as well today. We really appreciate you taking the time out of your hectic diaries to join us. We hope that you've been inspired by and enjoyed this spotlight session. Thank you again to Sarah, Jo and Robin and Amy for the great presentation and your responses to all the questions. It's a real pleasure to have you and your colleagues with us. And we look forward to hearing more about the next phase of your QI journey. Just a reminder to everybody, if you'd like to find out more about evidence for QI or follow up with Sarah and the team, please drop a note into the chat and we'll reach out to you. So this concludes the webinar. Thank you for attending. We hope to see you all at the next spotlight session, if not before. Thank you very much, everybody.
Thank you very much. Bye-bye.